Hello, everybody. We're going to start the healthcare session now. Thanks so much for being here. We have a really exciting session for you today. My name is John Gruber. I'm the chairman of the economics department here at MIT, and my work is in healthcare economics and healthcare policy. We also have speaking Kate Kellogg, who's the David J. McGrath Jr. Professor of Management and Innovation and a professor of business administration at the MIT Sloan School. Kate's work is helping knowledge workers and organizations develop and implement narrow AI and generative AI solutions on the ground in everyday work to improve decision-making, collaboration, and learning. We have Joe Doyle, who's the Irwin H. Shell Professor of Management and Applied Econometrics at MIT Sloan School, as well as the co-chair of the health sector at the J-PAL Action Lab and co-principal investigator of the NBER Roybal Center for Behavioral Change in Health. Through all these many initiatives, Joe partners with large healthcare providers and payers to conduct randomized controlled trials aimed at improving healthcare delivery. And then finally, we have Michael Yaffe, who's the director of the MIT Center for Precision Cancer Medicine, the David H. Koch Professor of Science, professor of the MIT Departments of Biological Engineering and Biology, intramural faculty at the Koch Institute, and also a real doctor. So if any of you are having pains or whatever, you can ask him during the session. His laboratory studies how signaling cancer cells, focusing on cell stress, DNA damage, inflammation, control the response of tumors to conventional and novel types of cancer treatment. And he's particularly interested in building the bridge between basic biological science and clinical treatments for human disease. So, great panel here today. We're each going to talk for about 10 minutes and then hopefully have a little time for Q&A at the end, depending on how much we abuse our privileges. So I'll go first, and I'm going to talk, if you can put my slides up, I'm going to talk today about risk sharing in the life sciences. So we're just waiting, I think, for my slides. Anyway, there we go. Insurance, paying for health insurance in the life sciences. Great. So let me see. I think if I go like this, it'll go to the note. That's the pointer. If I go like that, how do I get to the next one? How about that? There you go. Okay. So today I'm going to focus on risk sharing. This is a term economists use glibly, but let me be clear on what I mean, which is that medical risks are the greatest risks facing most Americans. They're difficult to prepare for, and they're large and unexpected. So what do we do as society? As the developed societies all around the world, we spread that risk through insurance. How does insurance work? We prepay a fixed amount in return for coverage of our medical costs when we need care. Okay, and so that's how we share the risk of getting hit by a car, having a heart attack, or developing cancer. We prepay now, and then later, those costs are covered. Now, in that world, we have to recognize that life science innovation is incredibly expensive. New innovations in life science are expensive, becoming more so. The estimates suggest that the cost of developing a new drug is $2 billion. That results in high prices to the end users of those drugs. Those high prices are what we need insurance for. And we need it because we are making miraculous steps in life sciences innovation every day. We can talk about a moderately expensive miracle, which is GLP-1s. These new drugs, which can be used to control weight and help with diabetes, have been shown in large trials to be massively successful at curbing weight and increasingly shown impacts on curbing other behaviors. And that's moderately expensive. That's $15,000 a year. Then we have incredibly expensive miracles, which is cell and gene therapies, which are coming online, which are literally curing the incurable. These are diseases which, through loss of a genetic lottery, was killing people. We can now literally cure them and let people who would have died at age 2 live to old age. They're miraculous. They're unbelievably expensive. A typical cell and gene therapy costs millions of dollars. So you talk about something you need insurance for. You need insurance against losing a genetic lottery and having to face a $2 million expense. But the U.S. insurance system has key holes. The first hole is discrimination. So before the Affordable Care Act was passed in 2010, it was completely legal in the US to discriminate against those who were sick in your insurance decisions. You could deny insurance coverage to someone who was sick. You could charge a sick person or a woman more for health insurance than you charge a healthy person or a man, or you could exclude those with pre-existing conditions from coverage. That ended with the Affordable Care Act. We banned discrimination insurance. Now insurers have to charge men and women and the sick and healthy the same price for health insurance. This is critical in a world where we can increasingly predict risk. Increasingly, I can tell who's going to be sick before they walk in my door. What that means is any profit-maximizing insurer is going to want to avoid the sick. So in a world where we know how sick people are going to be, it's critical that we don't allow insurers to discriminate. Now, the ACA solved this problem. It seems safe for now, but there are still opponents of this protection now in power in the government, and that's something we need to monitor. I think the ACA is pretty safe, but this would be a critical loss for risk protection if this went away. There's also the uninsured, however. About half of 25 million Americans lack insurance. About 25 million Americans, lack insurance. This was cut in about half by the ACA, but it could rise significantly. Their policy decisions matter here. The number of uninsured covered by the ACA went down by about 4 million under the first Trump administration, rose by about 5 million under the Biden administration, then fell and is anticipated to fall again. Who are these remaining insured? Many of them are actually eligible for free insurance today, and we could just automatically enroll them. Some are young invincibles, people who feel that they don't need insurance because they're healthy. And some are undocumented immigrants, which is by itself a political minefield. So it's going to be challenging to get these remaining uninsured, but it's an important goal if we want to once again protect against medical risk. There's also the fact that we have a multi-payer system. Individuals move across different payers. So if I'm an insurer and I have a decision about investing in preventive care for you, but by the time you're sick, you'll be with a different insurer, I don't want to make that investment. Why should I pay that $2 million for a cell and gene therapy that's mostly going to save money for some other insurer down the line? So insurers don't want to provide investments because people might leave and go to other insurers. On top of that, insurers are worried about these really expensive risks, these things like cell and gene therapy that are incredibly expensive. So what do? Insurers get insured. They buy reinsurance. There's a contract that says, look, you're insuring everyone at MIT, but if someone has costs above $50,000, we'll pick up the difference. They buy it from big companies that offer that reinsurance. The problem I realized recently is the ACA did not fix the reinsurance market. It's completely legal to discriminate. So MIT could go to reinsurer and say, look, we're going to cover the cell and gene therapy. And the reinsurer could say, nope, I'm not going to reinsure that. You're on your own for that. So there's still holes in the system, even for those insured, we need to address. So let's do an important case study. We're going to talk about innovation a lot today. Let's talk about one of the most innovative areas in medical care, which is cell and gene therapies. The adoption's actually been slow. There are some new cell and gene therapies being introduced, and the adoption's been slow, despite the fact they're literally miraculous and life-saving. Why is that? Well, insurers are very wary of paying for them. First of all, as I said, they have to make a major investment in paying for them, but they might not get the lifetime benefits of people staying on the plan. Second of all, these drugs are miraculous, but the trials are so far very short-term. We don't know if 5 years from now they're going to stop working. And insurers are like, I could pay all this money, and 5 years from now, it could wear out and stop working. And so as a result, I'm wary of making that investment. And finally, reinsurers won't cover these drugs in many cases. So insurers have been slow to adopt. When they do adopt, they try very hard to limit who can get these new innovations. The problem is people can't afford them without insurance. And life-saving opportunities are being missed. And this can in turn feed back to investment in these new areas because people are reluctant to invest in cell and gene therapies because they're afraid they won't be covered. So what do? Well, single-payer health care is not walking through the door in the US. It's too politically difficult. But we do actually have single-payer health care in the US. People don't realize it. We actually have single-payer health care in the US for a particular disease, renal failure. For those with renal failure, they are on what's called the end-stage renal disease program, and it's a universal government-provided single-payer insurance. Why couldn't we do this for other diseases, say genetic abnormalities? Why couldn't we say for those born with genetic abnormalities, they will be on a government-funded single-payer insurance system? That would solve all these problems, and basically as a society, we'd all pay a little higher taxes because we won the genetic lottery to support those who lost the genetic lottery. It's a perfect case for a government intervention where we as society share the risk. Alternatively, if that's not feasible, we could think about developing private sector models to spread the cost with things like value-based reimbursement that allow us to have the manufacturer share the risk of drugs not working, and subscription models that put the risk on manufacturers. These are things that I'm working on, trying to see if we can push these in the private sector in the absence of a government solution to this problem. Now, last thing I'll talk about is what about pricing? These treatments are very expensive. You might say, well, why do they have to be? Why don't we just tell these manufacturers they can't charge much? And the answer is because innovation won't happen. Innovation does respond to financial incentives. So the traditional approach to dealing with this around the world is we measure something called comparative effectiveness. All around the world, they have organizations which say, look, if a drug only delivers this much of health value, we'll only pay this much for it. The US is the only country that doesn't do that. As a result, we pay dramatically more for our medical treatments than anywhere else in the world. The typical medical treatment costs about twice in the US for innovative treatments as it does in Europe. So that's something we could do in a step that was started with the Inflation Reduction Act. The problem is, for these incredibly expensive new drugs, they're actually worth the price they're charging. So they're charging $2 million, and you know what? They're delivering $2 million of benefit. So dealing with pricing in this new sector is going to be much more challenging, and we're going to need to think about other mechanisms to deal with that. So finally, I guess the last thing I want to say is, how do we finance this innovation? This is another area economists are thinking about, which is basically we need to not only cover these things through insurance, but actually promote more R&D funding of these valuable things. This is discussed in my book, Jumpstarting America, where we talk about the role of public funding of research and development, which actually at its peak amounted to 2% of US GDP, and is now only 0.5% today. This funding complements private R&D, it promotes private R&D, and has huge economic returns. Yet, as I said, investments have been falling. So the bottom line is we need to think about creative solution to get more innovative funding in this area and to help share the risks that people face with expensive new treatments. I'll stop there. Thank you very much.
Hi, I'm delighted to be here today to talk to you about my research on narrow and generative AI, and both of these forms of AI have great potential to transform healthcare. Here's an example of narrow AI. Some of my co-authors at the Duke Institute for Health Innovation worked with hospital doctors to develop a highly accurate tool using machine learning, which detects unexpected patterns in patients in the ER to predict sepsis. And sepsis is a life-threatening illness, infection, where you need to predict it quickly in order to treat it quickly. Here's a generative AI example developed by some of my co-authors at NYU Langone Health, where they use GPT-4 to read clinical notes of patients who are inpatients and create patient-friendly discharge summaries for patients. And discharge summaries have been shown to be really important to transitions of care from inpatient to outpatient, and yet 88% of current discharge summaries are unreadable to patients. So clearly, these AI solutions can result in improved quality, reduced costs, and increased revenues, and that's often what developers are focused on. However, what they often do not focus on is the workers who need to implement the solutions. And based on my work with co-authors at Duke, we found that narrow AI tools often offer few benefits to workers, require laborious development, and also are a threat to user autonomy. And with colleagues at Langone, we found that generative AI solutions often have unclear applications, require laborious iteration, and result in harmful outputs. And workers don't like these solutions that make their lives worse. So how can developers design AI solutions for successful implementation? I've done research at Duke looking at their narrow AI solutions, and at NYU Langone looking at their generative AI solutions. And what we found is that each of these solutions have particular characteristics that raise challenges for workers. So the challenges with narrow AI are that it's predictive, laborious, and prescriptive. And with generative AI are that it has unclear applications, is laborious, and results in new risks. So developers need to design AI tools with worker implementation in mind. So with narrow AI, let's look at this predictive characteristic first. At Duke, what they've found is that specialists who treat patients for particular diseases often ask the developers to develop tools to flag patients at risk of developing these diseases. So as Jonathan just told you, AI tools in medicine, we're going to be able to predict a lot of things. And so this is great. We can now intervene earlier with patients with all of these disease states in order to have higher impact. The problem is, it means that upstream clinicians are expected to use these tools, and now they're bombarded with a host of narrow AI tools that they didn't ask for in the first place. So what they do at Duke is they identify the true end users, in this case, the primary care physicians, and they develop solutions to address their pain points. So in the case of a narrow AI tool which can detect chronic kidney disease early, what they found is that the challenge for PCPs is that they already have limited time to prepare for patients, so they don't have time to use another tool, and they also don't have time to ensure appropriate follow-up for patients who get flagged by the tool. So the Duke development team worked for solutions where it was the nephrologist who asked for the tool who actually are the ones who use it to detect this problem. They send their recommendations to an ER system, EHR system, which gives doctors the recommendations directly before the patient visit, and they provide dedicated care managers so that any patients who are flagged to be at risk get appropriate follow-up. Another issue with narrow AI is that it's laborious to develop. It requires a lot of back and forth between clinicians and developers before you can make these tools work. And so specialists came to Duke developers and said, help us detect low-risk pulmonary embolism in the ER, because a lot of patients with pulmonary embolism are getting admitted to the hospital who don't need to be admitted. And it's the emergency room physicians who need to use this tool who were initially asked to help develop it, and they said, we've got a lot of other things we're already working on. So Duke then went to the downstream vascular and cardiology specialists and got them involved in this laborious development to do things like validate outcome definition, make sure that model inputs were fit for use, and do a silent trial to test the performance of the tool. Finally, narrow AI is prescriptive. It tells doctors what to do, and that can threaten autonomy. In the case of the sepsis tool I told you about, it was rapid response team nurses who wanted ER doctors to use this tool to detect sepsis. And initially, they were the ones using the tool, and ER doctors didn't like having these people far away from the ER all of a sudden being the ones to detect sepsis on the ER doctor's patients. So the rapid response team nurses started, whenever an AI tool flagged someone with sepsis, they would do a chart review, but they would call the doctors in the ER to make sure the doctors were the ones who did the diagnosis and placed all the orders for patients with sepsis. So Duke developers have learned to increase benefits for true end users, reduce labor for end users, and protect the autonomy of true end users. Generative AI similarly raises particular challenges for workers. At NYU Langone, one challenge is that generative AI is general purpose, so it has a million different potential applications. And what they do is they involve the workers themselves in widespread decentralized experimentation so that it's the workers, not the developers, who are deciding what are the applications that are going to be most valuable for healthcare workers. And one way they do this is promptathons, where they provide workers with basic education in generative AI and hands-on ability to use the generative AI with healthcare data sets in order to get a feel for things and begin to develop ideas for good applications. One developer said, GPT has these fascinating moments where it just does stuff, and that's motivating for people working with generative AI. Another challenge is that these solutions require laborious iteration. So for that tool I told you about with the patient-friendly discharge summaries, that required clinicians to go through dozens of patients who had been in inpatients and their clinical notes to figure out how to draft an accurate prompt that resulted in a good output for the patient-friendly discharge notes. What the developers do is they need to sustain worker motivation for doing this iteration on top of their regular job. And so they provide on-demand assistance in office hours, provide help with what they call prompt tricking, which in this case involves things like with GPT-4 using all capital letters when giving instructions, and even telling GPT-4 that you'll give it a tip if it gives you good outputs. Finally, generative AI presents new risks because of hallucinations, bias, and lack of interpretability. So developers use a Gen AI risk screen where they screen all potential applications up front to see which ones are worth developing. So in one department, clinicians came to developers and said, we really want to use generative AI to translate consent forms into other languages. But what the developers discovered is that GPT-4 tends to miss important nuances. So it's not a good technical fit with generative AI, and it also raises regulatory concerns related to this bad interpretation. So they stopped the development of that tool. So at Langone, they catalyzed this decentralized experimentation with promptathons, used this on-demand technical support, and also use a risk score to prioritize which projects are going to be best. So in sum, what I want you to take away from today is we often focus on how these tools are great for quality, costs, and revenues, but we forget that they often present problems for the workers who need to implement them. Developers need to address these challenges to design AI solutions for successful implementation. Thank you.
All right, hi everyone. My name is Joe Doyle. I'm an economist at MIT Sloan, and I do a lot of my day job is partnering with payers and providers to try to get patients to be healthier and providers to be more guideline adherent and do a better job. So I help run our health systems initiative at Sloan, and we have 3 pillars of research backed by about 30 faculty members and a bunch of PhD students working on health analytics, healthcare operations, and healthcare incentives. On the analytics side, we build new frontier tools, but also we have people like Kate who help think about how do you get those tools adopted in a meaningful way. Operations are to get more efficiency in our healthcare system, and then as an economist, I think a lot about these incentives. How do you get people to behave healthier? How do you set up the right procedures and incentives to get that to happen? So let me talk about one part of my research, which is randomized trials in healthcare delivery. You know, most drugs or medical devices will have some randomized trials behind them to show you that they're effective, but when we go to change how we're going to deliver care, there's much less that's done in that rigorous way that we can learn whether things work or don't work. And so I'm here to evangelize that we need more of this. So let me talk a bit about the economics underlying it. Here's a map of Boston, and if you think about the bus route 1, if you get on in Roxbury, the life expectancy is 59 years old. If you go a couple miles north to Back Bay, the life expectancy is 92 years old. So that's 3 miles buys you 30 years of life expectancy. So you often hear people say there's genetic code, there's zip code. This is the zip code part of it, that there's, through poverty and other social risk factors are major drivers of whether people are healthy or not. So healthcare in the clinic needs to sort of think a bit more broadly and think, well, what can we do upstream? How can we address the issues that are really driving a 30-year drop in life expectancy? So one way we think about it is, and John talked about the need for insurance if you get unlucky. Well, this graphic here shows you that 1% of the population drives about 30% of healthcare costs in any given year. And we're spending $4.5 trillion in healthcare in the US. So 1% of people are driving, have over $1 trillion of spending on them. If we could figure out how to treat those patients in a healthier way, in a more effective way, more efficient way, we could save a lot of money and improve their lives. So in the healthcare delivery literature, these people are called superutilizers or healthcare hotspots. And there was this really interesting article in the New Yorker a few years ago about hotspotting could make people's lives better and save money at the same time. So it was a profile of Camden, New Jersey. It's a high poverty city outside of Philadelphia. And Dr. Jeff Brenner, who's sort of a hero of mine, I'd say, he's a very inspiring physician there who organized the collection of data from all the healthcare providers into one health information exchange. And then they would try to figure out who are these hotspots and how can we treat them better. Their idea was to create a team of about 10 people, including nurses, psychologists, social workers, who would make home visits. You think about 5, 10 home visits to the superutilizers, send nurses with them to their appointments, and try to navigate that system in a more effective way. If you had all the healthcare problems that people in the 1% have, 1% of healthcare spending, then you would really appreciate having this team of people there to help you. So here are the number of admissions leading up to entry into that program and then afterwards. And you can see in the quarters before, you see a ramp up. People got unlucky. They lost the genetic lottery or some kind of lottery, and they are going to the hospital more. That's how you get into the program. And then after they're in the program, their costs fall. And that's exactly what the New Yorker article and hotspotting programs that were popping up all across the country were pointing to this graph and saying, we could save a lot of money and improve the lives of these people at the same time. Now, economists and health service researchers wonder, well, what would have happened if they didn't get that program? What we call the counterfactual. Against the fact that they got the program, what would have happened? Well, the nice thing about a randomized controlled trial, you flip a coin and figure out who's in the treatment group, who's in the control group. The control group gives you the counterfactual. What would have happened if we flipped the coin and got heads instead of tails? And so in the orange bars, that's exactly what happened to the control group. It exactly mirrors what happened in that treatment group. They got lavished care, all these home visits, phone calls, appointments, collaborations. And so what we learned from this experiment is that the drop in healthcare spending was a bit of a mirage. It wasn't the program that did that. When people get healthy and unlucky, they tend to get luckier than they were before, and they sort of revert to the mean. Now, I wanted to go into this program and say, well, let's show that this thing works so that it will spread even faster than it's already spreading. This is a very inspiring program, helping people both in their clinical needs and their social needs to improve their health. And what I learned was that it's not going to be sustained by lower healthcare costs. We might want to pay for it for other reasons, but we can't make the claim that we're saving money at the same time. And it might have felt good to pat ourselves on the back and say we're saving money at the same time, but if you're not actually doing it, then you're just going to chase your tail. We need to know what works in order to have that spread so we can make real progress. So, the paper came out just before COVID. It made there was a lot of attention devoted to it because this was a very popular program, like I said, sprinkling up all across the country. And what folks said across the country was, well, I used to assume that this works. This seems like it should work in our own data, our own dashboards. People get healthier after they go in the program. And what they had to do is go back to the drawing board and figure out, does it work in my area or not? So when going from a presumption that something works to actually let's figure out if it works, that's what we do at MIT. We actually try to figure out what works in a rigorous way so then we can march down the path of progress as opposed to window dressing that feels good when you say that you're doing it. So I partnered with Geisinger on another study that targeted patients who had diabetes, and they were uncontrolled according to the clinicians there. They had a blood sugar, this HbA1c level, over 8. So to put it in perspective, over 7 would be diabetic, and over 8 they call it uncontrolled. On average, people had a score of over 10. And if your doctor tells you have an A1C over 10, that's kind of a scary number. So this program was also inspiring. It gives lots of healthy food to these low-income patients with diabetes. It gives about 10 meals per week, not only for the patient, but for their entire family. They go to a clinic every week to pick up their groceries. And at the clinic, there's a dietitian, a nurse, and a community health worker that will try to address their needs, do food exams, have dietitian consultations, have teaching, cooking classes, diabetes self-management training. And these are brand new clinics that are well lit with staffed with super friendly people. People love going to these clinics. But what I found was, again, a mean reversion story, that when they were targeting the people with very high levels of A1C, the treatment group got healthier, but the control group also got healthier. And it was back to this mean reversion story. And so what am I taking away from this sort of now growing evidence that when you target people with a pretty sick, some measure that they're pretty sick, so there's a high blood sugar level or high spending in the last year, you really have to be worried that they might mean revert. So one idea is you can't just trust those dashboards that you're seeing that people are getting healthier. If mean reversion is a story that you have to worry about, you can't just rely on a pre-post comparison. You need a credible control group. The other idea is to target durably eligible people. So this is the research I'm doing right now, is I'm finding that if you could predict who would get healthier regardless of the program, then you could target the scarce resources of this program toward the people who would actually need the program. And when I did a reanalysis of the people who predicted to not get healthier on their own, based on what we could observe when they enrolled in the study, those people, their HbA1c would fall by more than a point if you gave them the program, which is better than a lot of drugs. So getting people off of drugs toward healthier food, which is the initial goal of the program, but learning how to target it in a way that actually makes that difference, as opposed to just hoping that you're making the difference. And also, just back to that bus route map, social risk factors are obviously important. So there's just more work that we need to do to learn how to address them. We don't just give up on those 1%. We think about, well, what we were doing before wasn't working to save money. Let's see if we could, other programs you could do, like better remote monitoring, other technological solutions that you'll be seeing here at MIT throughout the day. Just really quickly, just to point out that I work with Geisinger on these large-scale messaging campaigns. So you might get these text messages reminding you of your appointment. Well, what should be in those messages to get you to do healthy behaviors like get your cancer screenings on time, get vaccinated, and so on. And with machine learning, we can try to target those messages, figuring out exactly what types of messages get you to behave in the healthiest ways, at least giving you that advice so that you can choose to do so for yourself. At Sloan, we're working with Quest Diagnostics, which takes blood from almost every American every 3 years. Everybody will go into there at some point. And we're doing randomized controlled trials to see what we can do to get people to be healthier when they get those results back. And then I just wanted to end on, you don't need to always do a randomized controlled trial. Sometimes with data analytics, we can do more. So just my last example here is, the x-axis here is birth weight. And at 1,500 grams, 3 pounds, 5 ounces, that newborns below that are labeled very low birth weight. And what you can see here is that as you get lighter, we spend more on you. And you see a discrete jump if you go across 1,500 grams, because especially at lower level hospitals, they increase the amount of treatment they give you if you get categorized in that way. And then what we see is as you get lighter, the mortality rate's rising, but it falls against the trend if you cross that magical threshold that got you the extra care. And so here, if we're rooting around for waste and value in healthcare, here's a place where people born just above and below that threshold is like a genetic lottery or a birth weight lottery. Some people win the lottery and they're actually too light. They're just below the threshold. They get more healthcare and actually they get better outcomes. And then this was replicated in other countries like Chile. Here's the mortality result for Chile. But here's 8th grade test scores, or first to 8th grade test scores. If you were born too light, you do better in school in Chile, and you do better in school in Norway. This is in high school, you're better off if you were born a few grams less at the time that you were born. So there's a lot to do, and really appreciate you guys spending the day with us here at MIT to figure out how we can do it together. Thanks very much.
I'm Mike Yaffe, and it's a great pleasure to be here today. As you heard, I'm a professor in biology and biological engineering, and I direct the MIT Center for Precision Cancer Medicine, but I'm also a practicing clinician. I'm an intensive care physician, and I'm a practicing surgeon. And what I'm hoping to do in the next 9 minutes or so is to connect this session on healthcare delivery with some of the basic science and engineering concepts that we heard about during the first half of this morning's session. And so to start off, I'm going to focus on cancer. And just for fun, I took every paper that had been published in Cell or Nature 43 years ago in 1981 that contained the word cancer, and I used deep learning to build a word cloud. And the words that jump out at us are things like gene, protein, DNA, virus, transforming principle. And in fact, that fit with 1981's view of cancer as a genetic disease in which oncogenes were turned off or tumor suppressor genes were silenced. And MIT was at the very center of this work. In fact, many of those papers in Science, in Cell, and Nature were authored by the luminaries here at MIT, Bob Weinberg and Phil Sharp, David Hausman, Rudy Yanish, Sheldon Penman, David Baltimore, all the people that you heard alluded to this morning. The problem is, let's look 42 years later. There are many more papers about cancer in Cell or Nature, and so I limited myself to the first 160 papers that I could identify, and now all of a sudden the main text in the abstracts are things like patients, human treatment, therapeutic response. This should be very worrisome for us here at MIT because we don't have a hospital. We don't own a medical school. Fortunately, however, if you look a little deeper, there are many ways that MIT can contribute because underlying this is a much more systems-based approach where instead of just oncogenes, now we see the immune system and the tumor microenvironment, metabolic defects and signaling defects. And so using that, I want to talk about how in the future we're going to bridge the divide between the clinical world and the basic science world. And I'm going to use my own lab's research just as an example of how to illustrate this. So I want to leave you with 3 take-home messages. The first is that the future of precision healthcare has to be an active and ongoing dynamic collaboration between clinicians and basic scientists. In 1981, the basic science was revolutionary, and it was directing clinical care or beginning to illuminate clinical care. Now we have to go both ways in order to do this. And an example that I'll use for this is our lab's research related to tissue injury. We've been very interested in tissue injury in the setting of both trauma and cancer, and in particular, how tissue injury is sensed by the innate immune system and how that interacts with the blood clotting pathways to further stimulate the immune system for or against tissue injury. And this was work that is the typical kind of thing that a biologist does in his lab, doesn't think too much more other than the system in which we're looking at until the COVID pandemic came about. And I say that because during the COVID pandemic, as you know, many additional intensive care units were opened across the city. All of us that are intensive care physicians got recruited to take care of those diseases. And it was clear to us that this was a very different type of respiratory failure caused by this virus. It was not the same respiratory failure that we saw in patients with pneumonia or patients with sepsis that Kate alluded to. This was a disease where the mechanics of the lung were completely normal. But for some reason, the lungs were unable to transfer oxygen into the blood. And that turned out to be due to a blood clotting problem that was induced by the virus. In fact, what the virus was doing was activating the immune system and causing microvascular thrombosis, something that's been referred to as immunothrombosis. Well, this turned out to be exactly the process that we had been studying in a completely separate context related to cancer and tissue trauma. And this ultimately then led us to use clot-busting drugs like Alteplase, a drug that we use for strokes and heart attacks, to treat these patients who had COVID-induced respiratory failure. That was the STARS trial. It grew out of the basic research here at MIT. Let me spend a minute and tell you how a failed operation completely changed my view of inflammation, tissue injury, and cancer. In 1987, when I was a medical student, I was invited to participate, which really means hold retractors, in a case where a patient had pancreatic cancer. And in those days, in 1987, we didn't have the imaging that we have now. And every patient who had pancreatic cancer went to the operating room, and we would make a big incision and take a look and make a decision based on what we saw about what to do. And this operation, unfortunately, was what we called a peek and shriek. We made a big incision, we took a look, there was cancer everywhere, it was obvious, there was no benefit to operating further on this patient, and so we simply closed the incision and told the patient to go home and enjoy the last few weeks of her life. 2 years later, when I was an intern, this patient reappeared in the emergency room with a bowel obstruction. 2 years later. Now, no one wanted to operate on her, but eventually we had to, and when we operated on her, her bowel obstruction was due to a single adhesive band. There was not a spot of cancer left anywhere inside her body. And this idea that injury and trauma combined with live tumor cells, because we hadn't resected any of the tumor, could somehow activate the immune system and result in a complete cure has motivated a fair amount of our research ever since. And here's a paper that we published just 2 years ago that shows how the injury response in live tumor cells can promote anti-tumor immunity. And I think that this ability to go back and forth between what we see in the clinic and what we see in the laboratory is going to lead to new approaches where we can combine surgery, chemotherapy, and immunotherapy more effective. Now, of course, we're always taught as physicians, above all else, do no harm. And so this has also made me wonder, maybe the tissue damage and inflammation and wound healing response from surgery is making some of my patients do worse. Perhaps I'm adding fuel to their cancers. What determines if surgery or injury or inflammation results in cancer cure or cancer progression? We don't know. But those are the types of things that we should be working on. The second take-home message I want to leave you with is we need to think about diseases and treatments, not in terms of single genes, but in terms of cell networks. Now, some of you may have a cardiologist, and maybe you have a pulmonologist, and maybe you also have a gastroenterologist. And you know how frustrating it is when you go to see those physicians because your cardiologist only wants to treat your heart problem. And he doesn't understand or doesn't think about the fact that when you treat the heart, you also affect the kidneys and the lungs and the brain and everything else. And as an intensive care physician, I don't have the luxury to treat just one organ system. I have to think about my patients in terms of how all those organ systems work together. The same is true moving forward with how we think about cancer. We can't think of cancer as just a mutation in an oncogene because the cancer cells are living surrounded in their microenvironment by other cells, including normal, and this is colon cancer shown here, including normal cells and additional stromal cells. And the same is true with genes in cancer. We can't think of a particular gene as being mutated. We have to think about how that gene is working in the setting of a network. And this leads to a new concept, which I'm calling network medicine. And that's because the connection between genes and proteins is different in a disease state than it is in a non-disease state. And this gives us a new way to be able to use disease-specific drug combinations. Because if certain nodes in this network are connected together in a disease state, I could use 2 drugs that target 2 different nodes, and those drugs would be particularly effective in cells in which this network has been rewired, whereas it would be much less effective in a normal state where only one of those 2 nodes is functionally wired together. In our own laboratory, we've discovered a way in which this works. We found a vulnerability that seems to be cancer-specific that relates to how cancer cells undergo division. And this has now led to 2 clinical trials and 1 proposed. One clinical trial uses 2 different drugs to treat castrate-resistant prostate cancer. Another uses 2 different drugs to treat metastatic colon cancers that contain a KRAS mutation. And a proposed trial is now going to look at using 2 particular drugs in a way that we think will dramatically benefit patients with ovarian cancer. And the very third point that I want to leave you with is the fact that many of the drugs and treatments we now use work differently than we previously have thought. Now, oftentimes when we prescribe a drug, we're fully aware that in addition to the drug, the way this drug we think works, there are a variety of side effects of that drug. But sometimes the side effects could actually be the mechanism. And as an example of this, we were working on a drug called 5-fluorouracil. This is a drug that's been around for 40 years. It is a standard of care that is used to treat advanced stage GI cancers like pancreatic cancer and especially colorectal cancer. And in fact, the textbooks will all tell you that this drug works very effectively because it blocks DNA synthesis. It targets this enzyme called thymidylate synthase, and that's how this drug works. There's just one problem with this, and that's if you look objectively at patients who respond to the drug or don't respond to the drug, responders in red, non-responders in blue, and you look at the level at which this target is expressed, there's absolutely no difference. How can the drug work in some people and not work in other people if the target of the drug is equally expressed in both? And I'll simply cut to the chase and say a few months ago we were able to publish a paper and show that in fact that's because the drug does not work this way. The drug works effectively in cancer patients because of a side effect. The drug gets incorporated into RNA, what Phil Sharp talked about this morning. And by being incorporated into RNA, it blocks the production of functional ribosomes, the machinery that makes proteins. And these functional ribosomes turn out to be essential in certain GI cancers. And that's the reason that this drug works particularly well. Now, my friends in computer science like to say, it's not a bug, it's a feature. And the same is true with medicines. Sometimes the side effects aren't bugs, sometimes they're actually the mechanisms of how the drugs work. So I hope I've left you with these 3 take-home messages for how I think MIT, as part of HEAL, can move forward. We have to have better collaborations, active collaborations with clinicians. We have to start thinking about diseases in terms of network medicine, and we have to recognize and explore the fact that many drugs we use probably work differently than we think. Thank you very much.
All right, so we are going to sit on the stage and do Q&A. I've got a couple of questions teed up, but I'd rather hear from you, so I'm going to start with one to get us started. And then, and we're all going to answer, but I really would hope we can hear from all of you. So if you have a question, you can come on up and stand at the mics, and I'll call on you if there are people who are interested. But let me start with one question. And you know, Mike, you sort of hit on this, but I'll let you flesh it out a little bit more, which is what makes MIT such a unique place to do what you do?
I think the thing that's so special about MIT is how incredibly smart all of our colleagues are. The students, the postdocs, the staff physicians, the staff scientists and engineers, and particularly all of the other faculty. Really, a great piece of advice I got from Phil Sharp was, if you really want to be successful, just surround yourself with smart people. And you can't find that anywhere at the density that you can find them here at MIT.
Okay.
For me, as someone who studies AI, MIT is just an embarrassment of riches. Literally, in every department across the institute, we have experts studying AI development and implementation. And that's great because it creates this ecosystem of researchers, not only within MIT, but because of conferences and speaker series, it means we get lots of industry practitioners and other researchers from around the globe to work with on the problem.
Yeah, I'll just echo this. When it comes to innovation, it's that levels of expertise at such world-class level across so many different domains that work together to make those innovations first get developed and then get implemented. That's pretty unique.
I think simply MIT is just a no bullshit place. I mean, basically, you can't do good work of the type we talked about unless you're incredibly rigorous and self-critical, and that happens more at MIT than any place I know. That's why our students sometimes are unhappy. And basically, we are just a place that believes enormously in scientific rigor. You saw it in Joe's presentation, the willingness to take on strongly held beliefs and challenge them. And you saw in the incredible science that's being done up here that MIT is just the perfect place to be working in areas where lives depend on it, because we don't get so full of our beliefs that we're not willing to challenge them and take them seriously. So I would add that as well. Seems like you might have some questions. Please go ahead. Scream it. Yeah, you go.
I'll scream it and then you can echo it
Yeah,
back.
no, we hear you now.
Oh, okay. So my question has to do, let me make an assertion first, which is scientists write to scientists or write for scientists. When I open up a Nature journal article, in order to understand that article, I've got to have some background. And I notice that a lot of you and a lot of the speakers today have behind their name MD, PhD. So when you talk about communication between the scientific community here at MIT and the clinicians, the practitioners across the river, the ones that don't have that PhD as well as the MD, how are we going to bridge that communication gap?
Well, Michael, you're a natural person to start on this.
I think that's a brilliant question. And I don't have an easy answer for it, but something that I've been arguing for a long time is we need to embed PhD scientists for at least internships or short visits into the clinic itself. The only way that people are going to learn to speak the same language is if they live in the same community. And so I think some interchange in which basic scientists spend some time with clinicians, and clinicians have the opportunity to spend some time in our laboratories here at MIT. In fact, one of my surgical colleagues is sitting here in the third row because he's decided that he wants to understand, he wants to get a deeper understanding of health economics. And I think that ability to go back and forth and to embed in each other's cultures is the only way we're going to make progress.
8, Joe?
Yeah, I mean, I guess I would just add, so I'm an ethnographer, which means I'm an anthropologist. So I train my students to go do exactly this, where they embed. But I think one other thing we try and teach them is to really understand what are the problems of the people in the setting, not problems that you come in with, but problems that they're really dealing with, because that's where the most interesting work happens.
I'll just say really briefly, at the Poverty Action Lab here at MIT, we put out a lot of policy insights and things that are geared toward policymakers as well as practitioners, and something that you guys can look up after today.
Yeah, I just want to add, the question was talking about clinicians and researchers, but let's extend that further, which is, let's talk about Kate's work and about how AI needs to speak to the people using it. And we need to be able to, and this is something I think MIT needs to work on. I think that's why I'm glad the School of Humanities and Social Sciences is involved with this Health and Life Sciences Collaborative, which we need to get better communication. We need to just not create the new science. We need to explain to people why it's important, why what we do is important, how it can change lives. And I think that communication needs to go not just PhD to MD, but PhD and MD to all the way down to people who don't have a college degree, so that everyone can really understand why we do and why it's important. Yeah, please.
Yeah, thank you all so much for the insightful comments and for the wonderful work you do. I was curious about this conflict between AI and autonomy, because I think there have been some studies published that show that, you know, these AI models are able to, for example, diagnose diseases better than a radiologist, but also there is this sort of like human, you know, like as radiologists, you are trained to do the same job. So I was curious about, should AI be taking over the role of radiologists if they are able to predict better, and sort of where do we draw the balance?
I guess I can start with that. So what we know from other technological revolutions is what we see is that some job categories get completely displaced, and that humans learn to do higher order thinking, higher order tasks. And so what's going to happen with AI, I think, depends on how fast the technology progresses and what frictions there are for deployment. But one thing for sure is that in the near term, many AI solutions are going to require human AI working together. And so what we're going to see is role reconfiguration, where humans used to do everything. Now they need to figure out what is the AI best at versus what are they best at.
Let me just add, the economics department of the Sloan School were blessed with the recent Nobel Prize jointly in economics, and the two people who won the Nobel Prize, Daron Acemoglu and Simon Johnson, wrote a book called Power and Progress, which is very much about this history and exactly the set of issues. So I urge people to take a look at that. Yeah.
Obviously, from your presentations, healthcare is a very complex area. There's so many different stakeholders, and there's competing incentives. It seems like healthcare, we're very reactive. We wait for all these trends and these diseases. Someone has cancer, obesity, diabetes, there's cost disparities, there's an aging population. Has there been any efforts to look at healthcare at time of birth? I know it's a long term, and we're a very reactive society. I want instant gratification, and we're dealing with the crisis when the thing is burning. But is there any analysis or any appetite for dealing with healthcare at an early stage so we're not dealing with such a snowballing crisis effect?
Michael, do you want to?
I would say the extent to which we've been able to address healthcare at birth is really through early disease testing. So there's some immune deficiencies that are now standard of care in all newborns so that we can diagnose those early rather than wait for those patients to then develop some immune-related disease, at which point it becomes much more expensive. Now, as genomics becomes more personalized, I think we will be in a better position to at least risk assess and decide who should get a test and who shouldn't, right? As you're probably aware, we're all in this dilemma about prostate-specific antigen, PSA. Should we use it? Should we not use it, right? And it only works if the prevalence of the disease is high. So I do think the place this will be helpful is once personal genomics really catches on, we should be able to risk stratify and better decide what tests people should get when. But I can't tell you about the economics of that.
Well, yeah, when we think about the incentives of the repair shop gets paid, there's going to be a lot of focus on repairing, as opposed to if the prevention shop gets paid, there'd be more focus on prevention. And so as the move in the US has been toward trying to put more risk on providers so that if they get people healthier, they would actually benefit from that as opposed to welcoming them back through the door. And that's a slow moving process because of all the stakeholders, but it's, I think, slowly surely going that direction. What do you think, John?
You know, one of my colleagues, Nathan Hendren, is running something called the Policy Opportunities Lab. And what this lab, Policy Impacts Lab, I'm sorry, what this lab does is actually quantify the social value of different interventions. And the ones that are most valuable are the ones on kids. That things that intervene at birth and early age are incredibly socially valuable, and I think we do need to be directing our focus in that area. Joe talked about some research on low birth weight, which does that. I think, you know, I talked about cell and gene therapies, which are really for these birth defect diseases. I think we need to be shifting our focus that way for sure. Yeah.
Building up on a comment on the stakeholders' misalignment and the reimbursement model. We have been talking about value-based care for a long time now and have not been able really to accomplish, at least in oncology, very significant progress. Where do you see is the best way to try to accelerate that?
I'm sorry, I didn't quite understand.
The value-based care model.
Value-based payment. Yeah, so basically this is a really interesting and important issue. Like I said, we've got these drugs that look incredibly good in early trials, but we're not sure how well they'll do. And I think that actually the government is recently putting together an initiative on this for sickle cell. There's new genetic treatments for sickle cell, and the government just today announced that they've got a new initiative to work with states to set up essentially a rebate system where if the drug doesn't work, the drug companies will rebate the money the states paid in. So I think we're making good progress there.
But I also think it's been somewhat of a failure of the economists said, like I said, just change the incentives and value-based payment will take care of itself. And it turns out it's incredibly hard. You have to put a lot of work into it. That takes time. So it wasn't going to happen overnight. I don't think people who knew this area knew it wouldn't happen overnight, but I did think it was going to happen faster than it has, because I thought the providers would know where the waste is and where a bit more than the payers did. And it turns out we all need to figure it out. But changing the incentives is the first step, not the last.
Last question.
Hey, yeah, sorry, this is kind of a technical question, but and we've got a broad panel today, but still, I'd like to ask it. The sobering statistic that I've come across in a couple of different places, including with Michael's lab, is that maybe only about a third of patients benefit from putting all of our best data together for personalized medicine. So in the context of the best care we can bring to patients. And as Michael knows, I'm sort of betting on the computational biology AI racehorse to really help us there. But that's only a piece of the picture, I think. So from a collaboration standpoint, I just wonder if the rest of you and together Michael just have some initial ideas about how we may make progress through collaboration on this really, again, very sobering fact that all of our best efforts with all this great technology, it's only helping a small portion of our patients right now. All the omics, you know, proteomics, genomics, all the rest of it combined, it's not getting us nearly as far as we need to, as fast as we want to. So, I'd like your thoughts on that.
So I think part of the reason, what Scott Ritter-Bush is talking about is the fact that at least using genomics, right? Genomics hasn't really, only 10% or so of cancer patients really benefit from genomic analysis of their tumor. Only 10% or less actually have a change in therapy that results in improvement. And part of that, though, is because we've been so heavily focused on genomics. So I do think just integrating in a patient-specific manner, other types of omic analysis, looking at metabolism, looking at immune infiltration, looking at proteomics. Now, right now, that's harder to do because we have not evolved the technology that allows us to do this in a rapid, high-throughput way on patient samples like we can do with genomics. That's exactly the kind of thing we can do at MIT. But the other part of it is we can't do it in isolation. We have to do this together with looking at patient historical records, risk assessment, family history, and that's even harder to incorporate into that type of thing.
Yeah, I would just add, it's a great question, great comment. I just add, you know, as a society, we play a role in directing technological advance, and I think we need to be thinking about directing technological advance to things which are helping a narrow slice of people very well versus broader set of people, maybe through birth improvements less well, and that's the kind of trade-off that economists love to think about and that we'll be working on. So I think we just stop there. Thank you very much for your comments and questions.